Okay, so the next one is from a fella, Haverick. It says, "Hi Doc, I've been reading about several peptides like ipamorelin, secretagogues like MK677, and of course GH, etc., etc. Do you have a recommendation of an addition to complement TRT for long-term, relatively safe, affordable, and sustainable use that I can take side by side with TRT permanently? My goal is to help with staying cut and maintaining and or growing muscle long term. I'm a 33-year-old male on TRT. Love your content. Thank you so much for your time." Thank you, sir. Yeah, I mean, we kind of just went over this a little bit with regard to peptides. You mentioned some good ones, though. You left out CJC 1295, but ipamorelin's a good one. MK677 or ibutamoren, great one. I don't recommend GH. We've talked about how GH is illegal to prescribe anyway, unless you've got roughly 7 different wasting disorders.
So you would rather, just to stop you real quick, you would rather use MK677 than growth hormone, even if you could get it? Like, if you have your choice between the two, would you rather just...
If we had free market,
yes,
and you can get whatever you want.
Yes, legally.
Like, name a country, but don't. I'm sure they're out there where you just walk in, you know, I've heard toilets, you just, here's the money, here's what I want. But no, because, and here's why. Because especially, this fellow's 33 years old. If you can get your body to produce it rather than shut down your own production, doesn't that sound like a much more elegant way of doing it anyway?
Yeah.
Now, is it natural? Heck no. But you're not shutting down your own production, your natural production of it, if you will, to use the word differently, but the same word. So if I can get my endogenous production up rather than use exogenous, then, well, think of it this way too. Aside from just neater that way, what about if you ever run out of growth hormone or you run out of the secretagogue? In the case we're using the growth hormone, you've suppressed your own production. You got to wait for your own production to come back if it ever does. It usually does with growth hormone. But with a secretagogue, you told your body to go from its natural, if you will, level of here to here. So you got your 33-year-old level of, say, 200, and we're using IGF-1 as a measure. Okay, then you go to, I've seen things that aren't supposed to be possible. Let's say you go to 350, though, something you had when you were 20. And then you don't take it anymore for whatever reason, then you go back down to 200 rather than close to 0.
Yeah.
Doesn't that in of itself sound better? And how about another one? Well, again, we already talked about the illegalities of physicians prescribing it anyway.
Mm-hmm.
How about the cost?
Oh my God.
Have you seen what growth hormone costs?
Easily, at least, on the market right now, at least $600.
Even if you have a wasting disorder, and I've got patients that have HIV, which will allow a patient, an insurance company will cover, in other words, will subsidize the cost of growth hormone. It's ridiculous. I think you're talking about, forget about subsidies, you're talking about anywhere from $1,200 to $2,000 a month for growth hormone. That's crazy compared to ibutamoren's a couple $100 a month, I think, you know. I mean, that's a big difference.
Yeah.
So on every level I can think of, now, you're better off. Now, if you're talking about, you know, what I really consider crazy bodybuilder dosages, where I've heard guys using, well, I say bodybuilder doses, not to pick on them. Even the HIV literature is kind of nuts, where you're using 9 IUs in the morning and 9 IUs at night.
I heard that 18 IUs a day in one bottle, one vial.
Yeah, well, that's why they give you sterile water instead of bacteriostatic water. You're supposed to use it like that.
Yeah.
That's where I think the medicine is backwards, and we got to go back and revisit that. But that aside, even if you talk to, and I won't name names, but you know the guys that have been training the top bodybuilders in the world, if you talk to guys like that, they'll tell you, yeah, 5, maybe 6 IUs, but really, you know, that's just because they're nervous about, you know, what they're going to look like on stage. 4, maybe 5 tops, and that's for bodybuilder dose, okay? I've seen guys that use exogenous growth hormone 3, maybe 4 IUs, and they'll get their IGF-1 to somewhere around 350, 400. 350 is what, you know, 350 to 400 is what you're producing at your max, typically when you're growing 16 to 20 something years old. Okay.
That's your peak, okay.
And you know, we can take a step back from this and go, what does that have to do with anything, Rand? Does that mean it's necessarily good for you when you're 33? I'm not saying yes or no. There's a lot of juries, plural, still out on what the best is for, and then we go for what? For longevity, to avoid cancer, to have a better quality of life. So, I mean, this gets really convoluted when we start, hashing it out. But if you want to keep it within physiologic range, then you don't need more than 3 or 4 IUs of exogenous growth hormone. And if you can do that with a secretagogue, then why not?
Why doesn't every bodybuilder that I know, why is everybody using exogenous versus the MK6? Is it because they don't know about it, or?
Well, because the bodybuilders are trying to go supra-physiologic because it leverages the fat loss and some muscle gain that much more so. I mean, it's definitely, if that is your sole goal.
Yeah.
And I'm not saying that longevity isn't your goal or that you're sacrificing for it, although there's some studies that would argue that.
Yeah.
But that aside, there's no doubt that using 5 or 6 IUs is going to help dice you up for the show more so than, I don't care if you use 50 milligrams of ibutamoren, because there's a negative feedback loop and there's only so much your body will produce. Now, I said earlier, at some point, I've seen some numbers that aren't supposed to happen given a negative feedback loop. I've seen an IGF-1 of 464 and you go, that's not supposed to happen, man.
Really?
Yeah, that's with ibutamoren too.
Really?
25 milligrams.
Wow.
And I've seen it more than once, and I was I there making sure they weren't using exogenous GH? No.
Yeah.
But they were using ibutamoren, and enough of these were, in my judgment, they weren't lying to me. But my point being that typically you're going to be limited to somewhere under 400, between 300 and 400 for your IGF-1, again reflecting your GH levels. And with exogenous GH, you can exceed that and therefore get more benefit.
Okay. In
this particular case with GH and IGF-1, you will get leaner and more muscle mass when you use it.
Okay, so that's
now,
why.
I did say though there's an upper limit. So going to 9 or 18 a day, then it's overkill.
Of course.
But there's that we'll call it a sweet spot there where you still get more out of it with exogenous if you're a bodybuilder.
Okay, gotcha. Awesome. Thanks, Doc.
Well, as I say, we got one more on this batch. And
it's a girl.
Again, thank you, ladies. We got 2 out of, 6 this time?
That's awesome.
So Amber says, hi, Dr. Rand. I'm a 30-year-old female looking to build more muscle in the gym. I have heard that testosterone injections can help, but I am concerned about the possible masculinizing effects of testosterone, and I'm not sure what dose is appropriate for me. I've never been on TRT replacement, no health or medical issues, and not taking any other medications or injectables. I read that female dosing of testosterone injections should be roughly 1/10 that of male dosages. What are your recommendations for testosterone supplementation in females looking to add a little more muscle while minimizing possible side effects? Thank you, Amber. So great, this is a good question. And Amber, you're correct. In general, 1/10 the dose works pretty well. So if you're using injectable testosterone cypionate, guys will use 200 milligrams per ml and use an ml a week, again, roughly. And females will use 20 milligram per ml strength and use 1 ml per week. That's a good general guideline for sure. And I would recommend injections in females if you're interested in ease of use. There's no question that guys do better in well, clinically speaking, in my practice anyway, with injectables. But females, I don't necessarily see a difference in results, whether they use injectable or a daily cream. Maybe because women just don't need as much testosterone as guys do. But I joke about, the executive types, if you don't want to be hassled with it, well then, use the once a week injection and get the same benefits. The difference obviously is in the, if you were ever to grab a snapshot, you're going to see more variability in the titer on a weekly basis, but arguably on a daily basis, you're going to see way more with the creams. In terms of, again, we go back to ease of use, times are changing, and I don't want to make a statement that sounds at all sexist, but if it's my wife, I joke I should have bought stock in Sephora a long time ago because she's got a cream for everything, and she's used to putting on this cream and that cream and stuff. Guys, I know times are changing, but not so much, at least in my generation. It was a pain to have to put on shaving cream this morning, right? So to add one more cream, a lot of the gals just say, oh, sure, no problem. And, male or female, there oftentimes is a fear of needles. But man, sticking yourself with a needle is nothing compared to a lot of things we do. I would argue most of it's a mental thing. So to be able to give yourself an injection once a week, to me, beats having to apply a cream every day, wait typically 5 minutes for it to dry, and then another roughly 25 before you can do anything where you might sweat it off or swim it off if you jump in the pool or whatever. So for ease of use, I would argue it's great. One thing I will add, because she mentioned 1/10 the dose, generally speaking also, for replacement therapy, we've talked about how guys will have to get, and we've known this since the 1950s, to at least 800 nanograms per deciliter of testosterone total to get clinical benefit. With females, it's interesting because to get clinical benefit, we're going to see the numbers go off the charts even more. So it freaks out a lot of patients as well as practitioners to see the upper limit of normal being tripled to get effect. So we mentioned earlier, the guy was joking, I think a female's top of the range is 49. Yeah, to get to clinical benefit, you typically have to see roughly 150 nanograms per deciliter in a female as your minimum. So triple the high normal. Now of total, okay, which is just potential. Remember, that's bound up to get to a free, which is what's useful to you, of roughly the top of the range, 4.2 picograms per milliliter. Okay, just the way female bodies work. There's more of that total bound than with a male. So I hope that's helpful to all the ladies out there that are considering TRT. 35 years old by definition, by the way. I want to spew all the stuff I can about female TRT because we don't get these opportunities to talk about females that much. By definition, pretty much where perimenopause starts. So, again, without knowing whether you're a candidate by the numbers or by your symptoms and signs, the age is one that typically jibes anyway. Let me make sure I'm answering everything. Masculinizing effects. So, testosterone is not as big a culprit in all this as one of its metabolites, dihydrotestosterone, is. In terms of the androgens, testosterone's not that bad. Dihydrotestosterone is pretty bad with men and women. So with either one, in order to reduce those side effects, we want to block the conversion from testosterone to dihydrotestosterone. Now, first of all, though, any of the masculinization that occurs is either in your genes or it's not. So if you're going to get those hairs, and we forget this, men and women have hair in the same places. Women just tend to have a lot less of it. It depends upon if you're recessively gened or not, and we can go on and on. Even with recessively gened, in other words, the typical recessive gened Norwegian, with the blue eyes and the fair skin and the very fine hair and the attached earlobes I go on and on about phenotypes that have to do with recessive genes, can still get, hairy arms, let's say, which you associate more with the dominant genes and masculinization. But grandma probably had, a few hairs on her chin that you didn't notice until she got tired of plucking them when she was 70. She just didn't care anymore. But they started about this age, and again, in your genes or not, but furthered by the exposure to dihydrotestosterone. So we can limit some of that, in other words, some of those side effects by limiting the amount of dihydrotestosterone produced. And there will be more produced, presumably, if you add some of the substrate, testosterone, to the equation early on. Or later on, I should say. So one of the ways to block that is with a drug called Finasteride. It's a 5-alpha reductase inhibitor. That 5-alpha reductase is this enzyme that either in the liver or locally will convert testosterone into dihydrotestosterone and cause some of the problems. Whether it's the excess hair growth, or actually women can lose hair on top of their head too, just in the same pattern, male pattern baldness as men do. Acne, same as guys. Doctors used to use spironolactone, which is a diuretic, aldactone, but I don't care if you're not an athlete. I do. I'd like to try and get you to be more athletic, any of my patients, and most of them are. But one of the worst things you could do for your athletic prowess, if you will, is to be dehydrated.
Yeah.
Why would you use spironolactone unless you had a concurrent problem like hypertension that you wanted to treat by using a diuretic? Why would you want to dehydrate someone when you can use something specific to your issue here, which is excess conversion into DHT, and that's pretty much all it does. When I say pretty much, there are other hormones that are created, like dihydroprogesterone or 5-allopregnanolone, things that might be useful to you too, but for the most part, people don't notice that you might be producing less of it by blocking this enzyme 5-alpha reductase. But it's an easy fix. It's very cheap. This drug Finasteride. You've heard about it because the brand names are Proscar and Propecia when it's manufactured and distributed and sold, I guess, promoted to guys for either hair loss or prostate enlargement. So we have an easy fix to
I didn't know girls could take it. Okay.
Oh,
That's
absolutely.
Okay.
It's a much better choice, arguably, than spironolactone. And I see more and more doctors using that instead of spironolactone.
Oh, good.
So let me just make sure we got all. So masculinizing effects, that's the big one. I don't know of any other side effects that she might mention that I might be missing, other than she specifically mentioned masculinization, right?
Yep. Awesome. Thanks, Doc.
Thank you.